programs at ACO. On behalf of ACO, I welcome you to the fourth in a five-part series of ACO's Practice Transformation webinars. ACO is a national association of 35 community health organizations dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and other Pacific Islanders. With the rapid changes that are occurring within the healthcare landscape, we hope we can better serve Asian American, Native Hawaiian, and other Pacific Islanders serving community health centers with latest information on practice transformation. The goal of this series is to provide you with the latest on quality improvement, meaningful use, accountable care organizations, and patient-centered medical homes, and explain how they affect all of you in your clinics. In the last webinar of this series, we'll also be providing you with an analysis on the culture and language access standards that we are seeing in these practice transformation efforts. Today's webinar is entitled Accountable Care Organizations, Implications for Community Health Centers Serving Asian Americans, Native Hawaiians, and other Pacific Islanders, and our speaker is Ignatius Bao. Ignatius is a leader in health policy analysis, particularly around patient-centered care and healthcare reform. Prior to establishing his own consulting practice, Ignatius was a program officer and program director at the California Endowment, director of health policy and programs at the Asian and Pacific Islander Health Forum, and civil rights and immigration law attorney at the Lawyers Committee for Civil Rights of the San Francisco Bay Area. He was also part of the community efforts that resulted in the creation of the first White House initiative on Asian Americans and Pacific Islanders, and was a principal author on the first report from the President's Advisory Commission on Asian Americans and Pacific Islanders. Ignatius is a champion for the Asian American, Native Hawaiian, and Pacific Islander community and a great ACO supporter and ally. We are honored to have him with us today for this five-part series. Today's agenda will include a 45-minute presentation and 15 minutes for Q&A. Before we get started, I want to review a few housekeeping items and let you know how you can participate in today's webinar. Here we are looking at an example of the GoToWebinar attendee interface, which is made up of two parts. The viewer window, shown here on the right, but maybe on the left of your screen, depending on your browser or computer operating system, allows you to see everything the presenter will share on their screen. The control panel, shown here on the left, but maybe on the right of your screen, allows you to participate in the webinar. By clicking the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going to the View menu. Please note that all attendees are in listen-only mode and will be muted during Ignatius's presentation. You may submit questions in writing during the presentation by typing them in the questions field. We will be reviewing questions as they come in and will address them during the Q&A session after the presentation. If you would if you'd like to ask a question, comment, you can also raise your hand. To raise your hand, click the hand icon on the control panel. Today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. With that, I'll pass the meeting over to Ignatius.
Great, thank you so much, and thank you everyone for joining us for, as Nina said, this fourth in a series of webinars that we're having. So this one is focused on accountable care organizations, which is really a new phenomena in healthcare reform. And what we're going to try to do is, during this webinar, talk about what exactly accountable care organizations are, what the requirements for the specific model of accountable care organizations that is created by the Affordable Care Act called the Medicare Shared Savings Program, ACOs. We're going to look at other federal, state, and commercial or private ACO models that are also being developed and implemented. And then we'll talk about the specific implications for community health centers who are serving medically underserved Asian Americans, Native Hawaiians, and other Pacific Islanders. During the course of the presentation and webinar, I'm going to be using lots of different numbers and lots of different terms, and so I really encourage, much more so than the other webinars, for folks to use the question and chat function to ask questions as I go along to make sure that I address your questions. So just to review, the whole purpose of practice transformation is to try to achieve the triple aim: to improve the patient experiences of care, so moving beyond health insurance coverage and focus on expanding access to care, which is still really important, really focus on once patients are interacting with the healthcare system, what kind of experience and can we optimize that experience of care that they receive. And then in the bottom left part of the triangle, rather than just focus on quality improvement, really thinking about how to improve the long-term health of a population that is being served. And then finally, perhaps the most important driver of accountable care organizations is really paying attention to reducing the overall cost of care. So the idea for accountable care organizations is actually not very new. It began in 2000 with something called the Physician Group Practice Demonstration Project, or the PGP Demonstration. And this was authorized originally in the year 2000, but it took about 5 years for the Centers for Medicare and Medicaid Services to actually find the organizations that were willing to be part of this demonstration and then begin its actual implementation. CMS also began thinking that this would be a 3-year demonstration project, but realized that it needed at least 5 years to really study to see what its outcomes were. And so in 2005, 10 very large medical groups, each of the medical groups had over 200 physicians participating. So if you look at your own community health centers and how many physicians you have on staff, you may have a lot of physicians on staff, but I guarantee that none of you have 200 physicians on staff. And so these are very, very large medical groups serving tens of thousands of patients every year. So in total, these 10 large medical groups serve 220,000 Medicare beneficiaries. And this demonstration was really focused on Medicare beneficiaries, so older patients 65 and older, or those who had a disability. It was still a fee-for-service model, so it was not part of managed care. These physicians were being paid for their services to these Medicare beneficiaries on a fee-for-service basis. And what the change here was that if they had performance, they would get this thing called shared savings. So shared savings were available if the medical groups were able to show both quality improvement and cost reduction. And so this was something that was going to be different, that it wasn't just quality improvement, but you actually had to show cost reduction. The demonstration focused on 32 quality measures, and you had to show performance on all 32 in order to meet the quality improvement goals. And then the cost reduction was very complicated. It was based on whether or not you had 3 years of, you first looked back, it was a looking back and looking forward. So you first had to look back to see whether or not what those past 3 years of costs were, and then there were these adjustments made, including risk adjustment, for what the cost might be for the next 3 years or 5 years of the demonstration. And if you were under those costs, then you got cost savings. The last thing that was complicated was that you had a way to assign which beneficiaries were going to be part of this ACO or accountable care organization or demonstration project. They looked at the primary care services, and while the beneficiaries could move around and actually change their primary care provider in the middle of the demonstration, that primary care provider still was responsible for the care of that patient. The other thing that was different was that the group practice, the physician group practice in this case, was responsible for looking at the costs of that patient or beneficiary assigned to them, not just their primary care costs, but all their costs, including their inpatient costs and all other billings. And so while they weren't actually providing those services, the shared savings formula was based on the primary care provider actually controlling these costs. So if you haven't lost me yet, what this is really trying to do is put responsibility on an entity or in this case, the medical group, for controlling both the quality, improving the quality, and reducing the cost of that patient or beneficiary, regardless of where those costs come from. And so this was what was really different about this demonstration, was that it wasn't just controlling your own costs, but it was really taking responsibility for trying to control the cost of that patient, regardless of where those costs came from. So what these groups did to actually try to achieve these quality improvements and cost reductions over the 5-year demonstration is actually very familiar to us if you've been listening to the previous webinars. So they used electronic health records, they used evidence-based guidelines and decision support, often generated by those electronic health record systems. They began developing individual care plans for each of those beneficiaries or patients. They did lots of care coordination and case management. They brought nurses onto care teams and assigned care teams to those beneficiaries. They used things like patient education and patient engagement and patient self-management, things that we talked about in the patient-centered medical home model in last week's webinar. They did medication reconciliation, especially during transitions of care, but they also did some really innovative and creative things like home-based monitoring and computerized telephone monitoring and reminders. For some of the homeless and other populations, they use community crisis intervention teams. And then for patients who are towards the end of life, they use things like palliative care. So it was a whole number of things that are familiar to us, as well as some additional innovative things like this home-based monitoring and palliative care. So did they succeed? Again, 10 groups over 5 years trying to improve quality and reduce costs. So there were a lot of evaluations done, of course, of this whole model, and the result was essentially very mixed. That while all 10 of the medical groups met their quality goals, met improvements on the 32 quality measures they're all working on, only 5 of the 10, or half of them, met their cost reduction goals in order to receive the shared savings that CMS was going to promise them. And those 5 medical groups achieved shared savings and received about $32 million for the 220,000 beneficiaries being served. Again, only half of the groups ultimately met the cost reduction goals. So this is very, very difficult work, but it is possible to achieve both the quality improvement and the cost reduction. So a little prematurely, something called MedPAC, which advises Congress and the federal government, CMS, on Medicaid and Medicare policy, looked at the preliminary results, and in June of 2009, before the Affordable Care Act was enacted, actually gave a very strong endorsement to this model and said that CMS should actually adopt the model much more broadly within Medicare. And again, this was even though the final results weren't in and the results were a little mixed, that the quality improvement results were really strong, but the cost reduction results were only half of the 10 groups being involved. Well, Congress took MedPAC's advice and actually wrote the model into law. And so the most popular way that it got included was through the Medicare Shared Savings Program model that I'm going to talk about at length. But the Affordable Care Act also allowed CMS to use the model in its innovation center and through state-based health reforms that I'll also talk about, some of the state innovation models that are going on as well. And so as a result of the Affordable Care Act, that was passed in 2010, in 2011, there were about 60 accountable care organizations, depending on how you count them. And the latest count earlier this year is that there are over 740 accountable care organizations. And so clearly, because of the Affordable Care Act, the number of these organizations has risen technically from 10 in 2010, when they were still in the demonstration, to now over 700 and climbing very, very rapidly every year. Here's a map that one of the groups monitoring this activity shows that there is at least one ACO in every single of the 50 states and territories. And in some like California and Texas and Florida and New York and Illinois, there's at least 30 and up to 80 different ACOs operating in those states. And so it is widely distributed. It is concentrated in some states more than others, but every state has been implementing, again, a combination of Medicare ACOs as well as Medicaid and commercial or private ACOs. So let's spend a few minutes and talk about the most common model, which is the Medicare Shared Savings ACO, or most commonly referred to as the Medicare ACOs. So we are going to take a poll here and have a brief break because there's hundreds of these ACOs that have been started up. We're going to ask you as participants if you are aware of any Medicare Shared Savings ACOs operating in your particular service area. And so among the hundreds, are any of them operating in your area? This may be a stretch for you because, again, these are focused solely on Medicare beneficiaries, so you would have to know who's serving the Medicare population in your particular area. If you can answer yes or no, we'll tally these up and then we'll talk about them. So I'll give you a minute or two to answer the poll. So as you're answering that poll question, the final rule for these ACOs came out at the end of 2011. So it took about 2 years to create the regulatory structure for it. It was very complicated. And those ACOs, the first one, actually started 2 months later in January of 2012. So there wasn't a whole lot of time to gear up and start. And what was in these regulations was essentially saying very much the same process that we found in the physician group practice demonstration program. So the first thing that we saw is that these ACOs had to be licensed in order to operate. Sometimes they were acting as a health insurer. They also sometimes needed a license to contract with healthcare providers. Many were brand new entities, and so they had to gear up very, very quickly. They had to address certain antitrust and other legal issues. And so it was very, very complicated. Any Medicare provider could participate in an ACO, including federally qualified health centers. There was some question initially whether FQHCs could participate in ACOs, and then CMS made clear that they could. But again, the number of beneficiaries or individuals assigned, and then the CMS came up with a new term. Rather than calling them assignment, they called it alignment. So the aligned beneficiaries were based on the primary care physicians. They had to have at least 5,000 of them in the ACO, and it was for a 3-year cycle. The next thing was that they used 33 quality measures, so very similar to the 32 that the physician group practice demonstration model had. And they're very familiar measures, some patient safety, preventative health services, but also some very condition-specific measures around diabetes, heart disease, hypertension, et cetera. Because it was so complicated, the model allowed people to get full credit for the quality improvement simply for reporting their measures. They didn't actually have to show improvement in the first year. The cost benchmark was very much the same as the physician group practice demonstration. It was based on a 3-year trend plus the national growth rate plus risk adjustment. And if you then went under that projected cost, you would then have a part of the shared savings. So this is the most complicated part of the shared savings formula is that if you met both the quality improvement and you stayed under that projected cost benchmark, then you could share in the savings of up to 7.5% of the benchmark in the first 2 years. But if you chose to also take the possibility of having a loss rather than simply the possibility of shared savings, you could also go up to 10% rather than the 7.5% of the savings, but you had to then take this loss. What ultimately happened was all the ACOs have chosen the track 1 model so that they're only having the possibility of sharing in savings. They have no risk of actually having loss. There's only a handful of the ACOs that have chosen track 2. So what were the results? These started in 2012. There were 114 of these ACOs that started in 2012, and here are the initial results. So after the first year, they achieved quality improvement on 30 of the 33 measures, so pretty well, but again, not a perfect score. 58 of the 114 did achieve shared savings. They met their cost reduction goals, and they achieved a total shared savings of $315 million. So pretty impressive among those 58, but again, only about half are achieving, similar to the physician group demonstration, only about half are actually achieving the shared savings goals. More shared savings ACOs are starting every year. So 89 additional ones began in 2015, bringing the total to over 330 of these ACOs now operating in 47 states. In 2013, there was a all community health center ACO that was launched up here in Northern California, based in Solano County. And there's now nearly 5 million Medicare fee-for-service beneficiaries in these ACOs, in these 330 ACOs. So what have we been learning about the challenges of these ACOs, these 330 organizations that are providing care in an ACO model? One is this backwards-looking then forwards-looking assignment is very complicated, and it's very complicated for the ACO to try to keep track of who is in their ACO and try to do the quality improvement with them. Yes, they can do a rising tide lifts all boats and try to do quality improvement across the board for everyone, but we really need to be highlighting and focused on those individuals who are in the ACO rather than all the beneficiaries that that provider might be serving. And so there's been a lot of talk about changing the assignment system. There's also been lots of talk about trying to change the measures, that there's too many measures, the 33 measures are too many, and then lots of technical questions about changing the benchmarks so that the shared savings are reflected a little more accurately. The other thing that the ACOs learned was that it was really important to focus on the transitions of care, just as we're understanding the importance of hospital readmissions, and the importance of long-term care, something that hadn't been really well coordinated with a lot of primary care providers or, frankly, with hospitals. And so, again, especially for the Medicare population, the older population, this idea of really creating much more than just a patient-centered medical home that focuses on primary care, but really coordinating that care across the continuum of care became really important. The last thing that a lot of the ACOs have talked about is that beneficiary engagement is really important, but it's been really challenging for the ACOs to try to explain what the ACO is and what it's trying to do, and then try to get those beneficiaries actually engaged in the quality improvement activities. So with all this, the Centers for Medicare and Medicaid Services has listened, and in December of last year proposed changing the regulations for the Medicare Shared Savings accounts, accountable care organizations, and then took public comments on those regulations. The public comment period closed in February of this year, and we haven't seen the final regulations, but we expect that they will be issued before the next round of these shared savings accountable care organizations regulations are announced in January of 2016. And so there'll be different rules for these new accountable care organizations starting next year. So some of the changes are they're going to expand the definition of primary care to include nurse practitioners and physician assistants and not just physicians. So it broadens the definition of who might be the primary care provider. Since only 5 ACOs are using the Track 2 formula for calculating shared savings, which has losses included in it, what CMS is proposing is a Track 3 that would allow people a higher share of the savings, but also experiment with something called a prospective assignment of beneficiaries rather than a retrospective assignment. So it would change the assignment or alignment process. They would also consider some adjustments to the benchmarks. The biggest adjustment would be that it would be a regional benchmark rather than a national benchmark. And so that would be reflected variations in cost across regions. And then one critical change for beneficiaries is that they would have to affirmatively opt out of sharing data with the ACO, whereas right now they have to be given much more notice and have to consent to how the data is being shared with the ACO. So there will be changes in those Medicare Shared Savings ACOs coming up in this year to make things even more complicated for us to track. But meanwhile, CMS has also been really busy trying to do some other things. So even before it launched the Medicare Shared Savings ACO in the Affordable Care Act, it created, through the Innovation Center, another model called the Pioneer ACOs. And what these ACOs required were a much higher number of beneficiaries. So rather than 5,000, it required 15,000 beneficiaries to be included in these Pioneer ACOs. And it was a two-sided risk arrangement, so essentially a Track 2 arrangement for all 3 years, so that you had to share loss as well as risk in that period. And so given this launch, 32 organizations did sign up to become Pioneer ACOs, and as a result, 28 of the 32 Pioneer ACOs that launched in 2012, after the first year in 2013, they achieved quality improvement on 28 of the 33 measures. So they actually didn't do as well as the Medicare ACOs, and only 11, so less than half, had shared savings of $68 million. So as a result of this not so great performance by these Pioneer ACOs, many of them actually have left the program after 2 years. And so only 23 have continued, and now many of them may not even continue in the Pioneer ACOs. So let me pause there, and as we're trying to correct some technical difficulties, let's see the results of the polls of how many Medicare ACOs you all are familiar with. So 42% of you said that you're aware of a Medicare ACO in your area, and 58% said no, you're not aware of any. So that's actually pretty good. It's a higher number than I thought, and it shows that those Medicare ACOs really are being widely distributed geographically. So I'm just going to keep going here. After the Pioneer ACO model, we have our third federal model called the Next Generation ACOs. These were just announced in 2015. They're still being finalized and haven't actually been awarded. CMS expects to have 15 to 20 of these Next Generation ACOs. And the big changes here are the kinds of changes that are actually proposed for the Medicare Shared Savings ACOs in the proposed rule in December. So beneficiaries can affirmatively choose assignment There are going to be regional adjustments to the benchmarks, and ACOs can offer some additional benefits and pay for them, and CMS would pay for them through the ACO. And so it's another way of trying to get more people to share risk, but also change some of the challenges in terms of assignment and benchmarks that have been plaguing these ACOs in their startup. So I'm going to shift then. These are the ACOs that the Centers for Medicare and Medicaid Services has authorized through the Affordable Care Act and through the Innovation Center. But there are many other ACOs. In some ways, there's more momentum for ACOs being formed through state Medicaid programs. And so these state Medicaid programs have been implementing these ACOs in various ways. Some of them are using simply their Medicaid program and implementing state plan amendments. Others are using Section 1115 waivers that they're negotiating with CMS. Some of them are using the state innovation model, as some states have gotten the state innovation model grant, and then others are using other ways to fund the ACOs. And so there are many examples of these. Some of the ones that I'm most familiar with are in Colorado and Oregon, and they're being called coordinated care organizations or regional care collaborative organizations rather than accountable care organizations, but they're essentially the same. There are some ongoing challenges of trying to find the right quality measures, that you can't use the same 33 quality measures for Medicare beneficiaries because you're now dealing with a different patient population. So here's a map that shows that 19 states have already implemented these kinds of accountable care models, again, using different names in their Medicaid programs, and many states are currently in consideration. So another state that I'm familiar with is in Connecticut, is about to launch a Medicaid accountable care organization through their state innovation model grant that they just received earlier this year. So some of those gray states are going to change colors and begin implementing models later on this year. In addition, there's also a lot of momentum besides Medicare and Medicaid for private ACOs or commercial ACOs to be formed. So these have been formed by hospital systems, the large physician groups that this model originally started with health plans who have largely felt left out of the model, and with employers directly. So one count of how many of these private ACOs exist is that it's 200, but it's very difficult to keep track of them, and they're growing literally every single day with new models being announced. There's many different shared savings formulas because, again, they're not bound by the Medicare or the Medicaid rules. There are some challenges, different challenges in the commercial context in trying to keep track of the total cost of care when those costs don't all go to CMS, and how you then track down those costs of care become a real challenge. And then similar to trying to adapt the model for a Medicaid population, trying to adapt the model for a commercial population, you may need some different quality measures. And so two of the most interesting models that are being implemented, one is in Washington State, where a health system, the Providence Swedish health system, has contracted directly with Boeing for putting all of Boeing's insured employees and family members into an accountable care organization. And so what the Boeing employees do is they get their care through the network of providers that Providence Swedish has put together, as well as the hospitals and the other providers that Providence Swedish has contracts with. And if Providence Swedish is successful in reducing the cost of care and improving the quality of care for those Boeing employees, then Boeing, as the payer, as the employer, will pay Providence Swedish shared savings. So this is a direct business-to-business relationship. There's no government involved. There's no health plan involved. It's a direct relationship between one very large employer and one very, very large health system. There's a very similar model that is being implemented by Intel in New Mexico, where they're doing a very similar contractual agreement with Presbyterian Healthcare, where again, Intel employees and their family members would go to Presbyterian Healthcare, would sign up for this model, would go to Presbyterian Healthcare providers for their healthcare, and if Presbyterian Healthcare is successful in meeting quality targets, quality improvement goals set jointly by Intel and Presbyterian, as well as reducing costs, then Intel, rather than just pocketing those cost savings, will share those savings back with Presbyterian Healthcare. Again, no Medicare, no Medicaid, no health plan, simply a business-to-business relationship between a very large employer and a health system. I expect to see more and more of these kinds of combinations coming up, using the principle of accountable care, but leaving public payers and even private payers like health plans out of the equation. So the next poll question is, are you aware of any other types of ACOs? So whether they're Medicaid ACOs, coordinated care organizations, whether they're commercial ACOs in your particular service area. So if you'll take a minute to respond to that. So aside from the Medicare ACOs, are there any other ACOs that you're aware of in your area? And as we're collecting those responses, the last news flash coming in, as many of you worked on HR 2 to restore and maintain funding for community health centers and federally qualified health centers. That bill that was just signed by President Obama also changes how physicians are going to be paid in Medicare starting this year. And one of the new ways that they're going to be paid is through accountable care organizations. That if they participate in an accountable care organization, they will get additional bonus payments in Medicare that they otherwise normally wouldn't get as part of their ordinary Medicare rate. So this is yet another hot off the press leverage point in which patients who are being served by Medicare providers are going to see pressures on those Medicare providers to become part of an accountable care organization, either through Medicare or through some other way of structuring the accountable care organization. So let me then shift to what all this means. There's a lot of talk, and it seems very unrelated to where community health centers are, who many don't see a whole lot of Medicare patients and are not so involved in trying to figure out, especially with large employers like a Boeing or an Intel, how they're going to reduce costs. Well, the theory is that as we continue with healthcare reform implementation, especially with the expansion of insurance and the expansion of Medicaid, that there's going to be less and less uninsured. We know that's not absolutely true because undocumented immigrants and others are still going to be left out of healthcare reform implementation. But the focus for the rest of the U.S. healthcare system is going to move away from insurance coverage to these questions of quality and cost. The other thing that will happen is as the healthcare exchanges get implemented and Medicaid expansion continues, more and more individuals, especially those previously uninsured, are going to be either in Medicaid or with the help of the health insurance marketplaces and subsidies in commercial health insurance plans. And so we're going to move more and more to looking at those Medicaid and commercial plans as places and leverage points to improve quality and reduce costs. So one way to think about this is whether it's a medical home or whether it's some kind of shared savings or shared risk model, the actual model name may change, but the movement towards quality improvement and cost reduction is here to stay. And so for community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, I think you can still wait and see what is going on because ACOs themselves are still an experiment and continuing to evolve. There's going to be many names: shared risk, shared savings, gain sharing, value-based payments, alternate payment models being used, but all of them are moving towards setting benchmarks and targets for quality improvement and cost reduction, and then triggering your payment, conditioning your payment on meeting those quality improvement and cost reduction goals. This is different than managed care because it isn't a pre-assigned global capitation rate. You don't get the savings until you actually look back to see whether or not you achieve the quality improvement and the cost reduction in the past. So one group that has been keeping track of this is the Catalyst for Payment Reform, and it is a really busy slide, but the key number is the 40% in the middle, that they count that out of fee-for-service payments in the commercial context, only 40% of them are tied to value, to cost reduction and quality improvement. So we still have a long way to go in moving the fee-for-service payment model to a value-based quality and cost reduction model. This is a really useful publication from the RCHN Community Health Foundation, and it talks about the implications for accountable care organizations, specifically for community health centers. And what they essentially say is focus on the things that you know are here in front of you: electronic health record implementation, health information exchange, quality improvement in medical homes. And if you focus on those things, which are in front of us now, you will be better prepared to jump into an ACO if you need to. And so in their polling results, again, not surprisingly, 64% don't know of another kind, a Medicaid or private ACO or commercial ACO, but 36% of you do. So again, this is less of a trend. I'm not surprised, but I actually think that the Medicaid and commercial ACOs are going to take off even more. And so in your area, focus on doing what you need to now do for practice transformation, especially through medical homes, and test to see where you're weak in terms of your own quality and how best you can do quality improvement for your own patients. Work on continued engagement of your staff and your patients, because that's something that you can bring to an ACO, is a staff and a patient population that is really well suited and prepared for the kinds of additional quality improvement activities that you're going to need. So we do know that in Hawaii, 3 ACO members have formed something called the Accountable Healthcare Alliance of Rural Oahu, where they're contracting with a Medicaid plan to ultimately share savings based on their quality improvement and cost reduction benchmarks. Again, they haven't quite implemented a shared loss into that ACO model, but they're working with their particular Medicaid managed care plan on this idea of conditioning their future payments on both quality improvement and cost reduction. We also know that we need to pay particular attention to disparities population. As I mentioned, we don't have a whole lot of experience. There's only one all-community health center ACO that has been up and running. And so we're also going to have to pay attention to the particular needs of vulnerable populations, like Asian Americans, Native Hawaiians, and Pacific Islanders, who will have language and cultural issues as well in terms of accessing care generally, and how ACOs are going to include these kinds of much more vulnerable populations and address things like health disparities is something that we also need to pay attention to in the future. So with that, let me open it up for questions and really encourage lots of questions. Again, this is really complicated, and so I encourage any questions that you all have.
All right, thank you, Ignatius. As you said, we will now begin the question and answer section of our call. As mentioned at the beginning of the call, we will start by answering questions submitted to us via the chat function. If you would like to submit a question, please do so in the chat box on the right-hand column of your GoToMeeting screen. Also, we can facilitate a live Q&A session, so if you would like to ask a question, please raise your hands by clicking the hand icon on the control panel. And so we'll go ahead and wait a bit for questions. All right, Ignatius, our first question is, FQHCs manage a unique population. Should the health center be involved early in ACO setup to assure that the population is addressed and shared savings are distributed?
So yes, just as the different models of ACOs for the Medicare population, the Medicaid population, or the commercial population are going to have to do things slightly different. One area is going to be what the ACO chooses as its quality measures. And so for FQHCs, while choosing something like diabetes will make sense, choosing something like a fall risk may not make sense for an FQHC population because there aren't that many older or frail individuals in that patient population to try to hold that FQHC responsible for. And so I think if there's an ACO or talk of an ACO forming in your area, yes, of course, participating in that conversation is going to be really important. And one of the things to bring to that conversation is, will the quality measures be relevant for the FQHC population? And then secondly, as I mentioned in the last slide, will there be sufficient services funded by the ACO, like language services, like other culturally and linguistically appropriate services, to support those patients in transitions of care, for example, in something like medication reconciliation with other providers in the ACO that really addresses the needs of that FQHC patient population.
All right, thank you. Our next question is, coming from Hawaii, could you say a bit more about the ACOs in Hawaii?
So again, there's a number of ACOs being formed in Hawaii. There is the one that I referred to that 3 of the ACO community health centers have come together to form with a local managed care plan. I understand that the health systems in Hawaii have also begun to launch their own ACOs, and I also understand that there's a number of the Medicare ACOs largely being run by organizations that are based outside of Hawaii, but including Hawaii in their service area with some networks of providers. So you are seeing all 3 models essentially being implemented, a Medicare model, a Medicaid model, and a commercial private model. Some of the large commercial health plans like United Health, Cigna, Aetna aren't in the Hawaii market, and so they're not likely to come in and implement a pure commercial model. You're probably going to see some different kinds of commercial models, again, driven largely by your health systems there.
Okay, and just a reminder, we can facilitate a live Q&A session, so we encourage you to raise your hand by clicking the hand icon on the control panel if you would like to ask our presenter, Ignatius, a question. Our next question is, aren't ACOs just another name for managed care? How are ACOs different than having managed care plans, health plans?
So this is a very common question that folks understand that the sort of contrast to fee-for-service, and again, remember, this is all in a fee-for-service context, that these shared savings are over and above the ordinary fee-for-service payments that you would receive. And so many people say, well, why are you going through all these twists and turns and creating new organizations and having these really complicated payment formulas? Why aren't you just putting these folks into a managed care plan? Well, what's different is that managed care does the calculation of what is called a global capitation rate is ahead of time, and then the health plan assumes the risk for paying the providers, negotiating rates with providers, and then if they lose money, they just lose money. If they save money, they keep the money that they save. They don't have to pass those savings back on to those providers because those rates were, that capitation rate was pre-negotiated with both the payers as well as with the providers. In a shared savings accountable care model, you're doing this complicated, you're projecting what the savings are, and if you actually achieve the savings, then you receive them. So the risk is actually much higher in some ways, and it's much, much more complicated than just moving people into a managed care where you're asking the health plan to assume all the risk. You're now spreading that risk all the way down to the provider, in this case, the physician, or in the case of community health centers, down to the community health center.
It seems that the ACO model was designed for the Medicare population. How would ACOs for CHC patient populations be different?
So because the model was based on the Medicare population and being over 65 or disabled or both, they had a lot of high need, a lot of high cost, and oftentimes quality wasn't very good. So across a Medicaid population or a FQHC population, you're going to see a much broader spectrum of healthier, younger patients, kids, for example, that are generally pretty healthy, or young adults who are generally pretty healthy now with expanded Medicaid, all the way to, again, folks that have multiple chronic conditions or people who haven't accessed health care and then do need a high amount of health care coming in. So for those populations, again, the question is going to be, what are the right quality measures to be holding that accountable care organization and its providers to? Do those measures really measure quality for that much more broad and diverse set of patients than just Medicare beneficiaries? And then are the risk adjustments and the shared savings formulas going to be fair and take into account, again, the different kinds of patients that FQHC or community health center might see?
Thank you. And here's another question. What are the most important things for patients to know if they are in an ACO?
So on the one hand, a patient doesn't actually even need to know that they're in an ACO, because this is really on the provider side of how the provider gets paid. And we wouldn't want a patient to change their behavior based on how they think the provider is being paid. On the other hand, because that provider is in an ACO, it's more likely the ACO is paying attention to things like patient engagement and trying to do more patient self-management, trying to do more proactive health education, trying to engage that patient in an individual care plan. And so whether we call it an ACO or a patient-centered medical home, if those tools are being offered by the ACO or by the provider, then what a patient who's coming to that ACO should probably pay attention to is, how do I access those tools? How do I access that education? How do I access those ways in which I can become more engaged in my own health? An ACO is more likely to have a more sophisticated health information system and a more sophisticated patient portal. So that's another way of a patient, how do I use this technology? Can that technology be accessible to me in my language, in a literacy level that's available and meaningful to me? And so asking those kinds of questions from a patient perspective and a family perspective will, I think, not only help the patient, but also help the provider.
Okay, thank you. And we have another question. Should health centers join multiple ACOs? Are there restrictions on who can join? If a health center is providing care for an attributed ACO patients but are not a member of the ACO?
Okay, so there's a lot of questions there of can a health center be in more than one ACO? Technically, the answer is yes, but because the patients of that health center, namely the primary care providers, which if these proposed regulations go into effect, would include not only the physicians, but if you have nurse practitioners or patient or physician assistants leading care teams and being primary care providers in your community health center, then the assignment process is based on those primary care providers. So you can only be assigned to one ACO. So if you have patients seeing one provider, that provider can only belong to one ACO. And so you could divide up your providers and say, these providers will be part of this ACO, and those providers will be part of ACO number 2. It would get pretty complicated, but technically it's possible. And then the question, the last part of the question was?
Are there restrictions on who can join if a health center is providing care for an attributed ACO patient but are not a member of the ACO?
So a health center could be part of an ACO and not have its primary care providers be part of the assignment or attribution or alignment process, and they could just be reimbursed or take part of shared savings for services that they provide. But again, if they're not the primary care provider, then we actually would want to encourage that patient not to come to the community health center, but to go to their primary care provider. So there may be some other services like health education or other kinds of things that the community health center is providing that make sense. But if that patient is coming to the community health center for primary care, but they're actually attributed to another primary care provider, we probably want to send that patient to their primary care provider and not to the community health center.
All right, thank you very much, Ignatius. There are no other questions, so this concludes the Q&A session. Before we hang up, I want to remind you all that if you have not done so already, there is still time to register for our next and last webinar of the series, which will be on Wednesday, May 6th at 12 p.m. Pacific Standard Time. This next webinar will focus on ensuring culturally and linguistically appropriate services and practice transformation initiatives. Register for this webinar at www.apsho.org. For those of you who have already registered, thank you, and we look forward to speaking with you during our next webinar. Goodbye.